Hi, everyone. I'm Dr. Ashley Bassett,
And I'm Dr. Catherine Logan.
and welcome to another episode of Ask the Sports Docs. We get a lot of questions from our listeners each week, and they're great questions. So rather than responding individually, we thought we would do these mini episodes where we highlight some of the best questions and our responses. So let's get started. Today, we're tackling the question, should I have surgery for my type 3 AC joint separation? So if you're a sports medicine or shoulder surgeon, you've definitely had this conversation with your patients. And if you're an athlete, you've probably Googled this after landing on your shoulder snowboarding or playing hockey or playing football.
And the truth is, the answer really isn't black and white. But to try and answer the question, we're going to review an article titled Functional, Radiological, and Scapular Motion Evaluation of Surgical versus Non-Surgical Treatment of Type 3 Acromioclavicular Dislocations. So this is a level 1 randomized controlled trial. It's aimed to compare the clinical outcomes of surgical and non-operative treatment of type 3 AC separations.
But before we get to that paper, we want to start with an overview of AC joint anatomy and injury classification. So the AC joint is the articulation between the distal clavicle and the acromion, and ligamentous stability comes from the AC ligaments, which provide horizontal stability, and the corticoclavicular ligaments, or called CC ligaments. And those include the conoid and the trapezoid ligaments, which provide vertical stability. When both the AC and CC ligaments fail, we lose vertical stability, and that's where the controversy begins.
Okay, so we're going to talk about the Rockwood classification, which when I see that, it like brings me back to the call room at Mass
Oh
General.
gosh, it's like
But
OICE all over again.
all right, the Rockwood classification separates AC joint injuries into 6 different types based on the amount of clavicle displacement and the direction of that displacement. So a type 1 injury is an isolated sprain of the AC ligaments, and there's no clinical deformity, and the x-rays look pretty normal. A type 2, it consists of a complete tear of those AC ligaments and a partial tear or stretch injury of the CC ligaments, and so there's slight elevation of the collarbone seen on the x-ray. So type 1 and 2 are what we call low-grade injuries, and these make up the vast majority of AC separations that we see, and they're very uniformly treated without surgery.
So moving on in the Rockwood classification to more uncommon but also more significant injuries. So a type 3 separation, which is what this paper is talking about today, consists of complete tears of the AC ligaments and the CC ligaments with more significant displacement of the clavicle, 25% to 75% compared to the other shoulder. A type 5 injury is similar to a type 3, but it just involves greater displacement of the clavicle, so over 100% compared to the other shoulder. And lastly, type 4 and type 6 separations are very rare, and they differ from the others in terms of direction of displacement. So a type 4 separation consists of the clavicle dislocating backwards through the trapezius, while a type 6 separation involves the clavicle displacing down into the chest, so inferiorly.
Yeah, not good.
No.
All right. So now that we have our anatomy and our classification systems down, we're going to dive into the article. So it's important to mention that this is a level 1 randomized controlled trial, which we do not often get in the AC joint literature. And the purpose of the study was pretty simple. The authors wanted to compare surgical versus non-surgical treatment for acute type 3 AC separations. And their hypothesis was that surgery would produce superior functional outcomes.
So this study included 70 patients, 35 randomized to the operative group and 35 randomized to the non-operative group. The mean patient age was 31 years, and surgery was performed within 21 days of the acute injury. The surgical technique used was the modified Weaver-Dunn reconstruction, as described by Copland et al. In 1995. So important point to make there, this is a traditional technique. They used K-wire fixation of the AC joint rather than the modern suspensory fixation that we're typically using.
All right, and the primary outcome was the DASH score at 12 months postoperatively. Secondary outcomes included the UCLA score, shoulder range of motion, scapular dyskinesis, radiographic alignment, cosmetic satisfaction, and return to sport, as well as complications. Patients were followed for 2 years postoperatively.
So what did the authors find? Well, let's start with the primary outcome. At 2 years postoperatively, there was no significant difference in DASH scores between surgical and non-surgical patients, meaning that their primary endpoint showed no superiority of surgery for type 3 AC separations.
So the surgical group was found to have higher UCLA scores from 3 months post-op onward. However, while this was statistically significant, the difference between the groups was pretty small. Importantly, it did not reach the 3.5 point threshold typically quoted for a clinically important difference.
Analysis of shoulder range of motion found better early motion in the nonsurgical group. However, by 2 years postoperatively, both groups exhibited full motion with no significant differences between the groups. And that early stiffness makes sense. It can be seen in the surgical group, and it was likely related to the 4 weeks of immobilization until those K wires removed that
Yeah.
we typically see in the operative group. So that makes sense.
Yeah. So, what about return to activities? Well, both groups performed equally well. The authors found that 92.6% of patients returned to work or sport by 3 months postoperatively in both groups. With regards to returning to pre injury level play, 86.7% of patients in the surgical group returned to their same pre injury level, while 80% of the non surgical group returned to the same level of play. Though this difference was not statistically significant, this result might favor surgical treatment in our athletes and might offer a greater chance of returning to their pre injury level.
As for cosmetic satisfaction, this is where surgery clearly won. In the non-surgical group, 44% reported being dissatisfied with the cosmetic appearance of their shoulder, compared to 14.8% in the surgical group. And this result was statistically significant. And that number is quite impressive. Nearly half of the patients who underwent conservative treatment disliked the persistent deformity that they were left with.
Yeah, that's a good amount.
Hmm.
So let's talk about complications. So surgery is never risk-free. The surgical group was found to have 10% complication rate, including 2 infections and 1 loss of reduction. So with regards to the non-operative group, 3 patients or 10% crossed over to surgery.
And lastly, the authors looked at presence of scapular dyskinesis. So for our listeners, scapular dyskinesis is the abnormal movement or positioning of the shoulder blade relative to the rib cage, often appearing as winging or asymmetry during shoulder motion, and it can result in pain, weakness, and reduced shoulder range of motion. So the authors found that 40% of patients in the non-surgical group had persistent dyskinesis, compared to 20% in the surgical group. However, this difference was not found to be statistically significant, and importantly, presence of scapular dyskinesis was not found to impact clinical outcomes.
Yeah, I thought that was pretty interesting because I was expecting when they said that, I was like, oh, that's definitely going to feel like affect their functional. But
It
anyway, I was
should.
surprised by that. Yeah.
Exactly.
All right. So there's a lot of important information here. So we're going to summarize basically, with this battle, who won. So the dash score, it was a tie. Range of motion, it was a tie. Return to sport, tie. Cosmetic appearance favored surgery, and complications favored non-operative management. So functionally, they are the same. Cosmetically, surgery looks better, but surgery carries surgical risk.
All right, so with that summary, back to our question today. Should you have surgery for your type 3 AC separation? Like most things in orthopedic surgery, in particular in sports medicine, I really think treatment plan has to be individualized. I definitely lean non-operative here, particularly in recreational athletes, those with low overhead demand, patients who are risk adverse, and those with minimal cosmetic concern and want the fastest possible recovery.
Yeah, but you have to remember when surveyed, most orthopedic surgeons prefer starting with non-operative treatment for grade 3 AC separations, and for good reason. I would say that I lean towards surgical only really in specific cases, and it's really about, that discussion with the patient, like high-level athlete, or if they're very concerned about cosmetic. But I also think that it's important to know, even with the surgery, it's not like cosmesis is perfect. I
Exactly.
think you're still going to have a bump there. It's not like, I think so. I think if I want the cosmetic, I want it to look perfect, just like my other side, I still think there's a little bit of that deformity at the AC joint. Even when it's perfect, it's still going to, lift up a little bit over time. So I don't know if, you have any different approach there, but, I think that cosmesis is still a little questionable.
Yeah, I completely agree with you. I always joke with patients, I'm not a cosmetic surgeon, right? Or
Yeah.
I'll use the phrase like you're trading a bump for a scar. Like, depending on your approach that you use, if you're going to put a tissue graft in, you do have to make, even if it's a small
Yeah.
incision, an open incision,
Yeah.
right? So, like, you are still going to have a scar there. You may not have that bump. It may not be shifting around. That bothers some people, but I completely agree. I think, like, cosmetic, is that really worth the risk when all other aspects looked at in this paper were a tie? I don't know.
Yeah. No, I agree. Always a discussion with patients, but this is never black and white. And that's why we talk about it so much in the literature.
Yeah,
So
exactly.
our final takeaways. So type 3 AC separations, they're always controversial. They always will be. This level 1 trial shows no functional superiority to surgery, and surgery improves cosmetic satisfaction at least, but both groups have excellent 2-year outcomes. So choice of surgery really just depends on your goals, your sports, your tolerance for risk, and how much you care about the big bump versus the little bump.
Exactly. Well, thank you for listening to this episode of the Sports Docs. Sorry, let me start that again. Sorry.
No worries.
Exactly. Very well put. So, thank you for listening to this episode of Ask the Sports Docs. Please keep sending us your questions, your comments, your ideas for future episodes. We really love hearing from you. If you haven't already, please make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. Until next time.